As we all know, the way that healthcare in terms of the entire industry is constantly changing. And so what we're going to talk about today is really the new healthcare landscape under the Affordable Care Act and take a look at a solution entitled DSM, or Decision Support in Medicine. Not since the introduction of Medicare nearly 40 years ago have we found ourselves in such a change in the healthcare environment. Decision support in medicine was created to address two main issues facing medical practitioners today. First is having access to information at the point of care that is organized and easily accessible. And secondly, to have access to original content written by top specialists in each field. So we're going to take a look at a little bit of context as to what's going on in the industry, what are some of the major provisions we see with the Affordable Care Act, and how are there resources out there that can help the practitioner really take a lot of this information that's out there and use it effectively and efficiently when facing a patient. So as I mentioned, changes are coming like never before. With the passage of the Affordable Care Act, as over time we start to see the different provisions enacted, there's going to be basically a sea change in patient care. The amount of time each clinician spends with a patient is sure to be shorter than it already is, and the number of practitioners is going to continually decline in the near future. You see 47 million new patients are estimated to enter the system, 90,000 doctors. There will be a shortage that's already evident in the industry, and of course retirement. As people near that age, there's going to be another large group of physicians leaving the industry. So to paraphrase Tom Hanks in a way, Houston Medical Center, we have a problem. In addition to the shortage of physicians, in addition to those huge numbers of patients that we see entering in the system, there's this move towards defensive medicine. Although the cost of medical malpractice insurance has declined recently, it reached its peak not too long ago. Doctors will sometimes perform unnecessary tests just to avoid the presumption of malpractice. If we even take a look at this map, there were 6 states back in 2010. Granted, these are huge population centers, but especially New York, PA, Illinois, Florida, and a few other states made up more than half of all of the paid claims for malpractice in the U.S. and represented about 25% of the population. So these are some really big things to keep in mind, that in addition to just facing in terms of pure volume, there's also that cautious side of wanting to do defensive medicine. And of course, a lot of medical professionals who are already out there and are going to say, I already have a point of care tool. So let's take a look at some of the tools that you may be using. And two of the large names that are already in this space we see here on the screen are both UpToDate and Dynamed. Now each of these resources have their own specialties, and the way DSM is built, it can live alongside these and other tools with some of the extra emphasis that you wouldn't see in either of these resources. Decision support in medicine was not created to take the place of any of these tools. Rather, it was created to give you an affordable option when budgets are tight to really add that second layer to give you the expert content directly from names that you can trust. So we see the way that content is presented in some of these other resources, whether it's a bulleted list for a point of care text or whether some long narrative text. Who is it written by? We see that in Dynamed the content is written by general practitioners and family doctors, and UpToDate mentions it's written by subject experts. The targets are slightly different. So you may find primary care providers really in terms of the Dynamed sphere, where clinical staff is really where UpToDate is focusing. We'll take a look, though, at the areas of DSM that will really make it that extra piece that some of these tools aren't able to present in a way at the point of care. As I mentioned a little bit early on, we have expert content. Well, what does expert mean? The content in DSM is coordinated by one of the leading medical publishing experts by the name of Lou Rines. Lou was the CEO of Saunders, Mosby, Churchill, Livingstone Incorporated, as well as Lippincott over the course of his 50-plus year career. He published many of the standard references. These include Nelson, Oskey, Fagan. You know these titles. You've seen them around. With his connections in the industry, he was able to reach out to over 60 MDs to come together as editors and associate editors to create new and original content. We also look at the number of contributors that those editors were able to reach out to. We have over 500 contributors that played a part in the development of this content. Specialists from 18 leading areas have already come together, with another 10 or 11 coming soon. The above logos are just a small sample of the institutions represented by the editors, and many more are covered by the contributors. So when you look at names like Johns Hopkins Medicine, we see University of Pennsylvania, Beth Israel Deaconess Medical Center, teaching hospital of the Harvard Medical School, University of Pittsburgh, Tufts, and others. You'll see the prestige behind these names and know that a lot of these institutions, pretty much all of these institutions, are meant to be at the forefront of medical research and what's going on in the medical world. So you can trust the names behind those institutions and behind the content that you'll see. Now, things aren't always what they seem, especially in medicine. Conditions that present themselves one way may actually be something completely unrelated. Keeping an open mind to alternative diagnoses and having differential diagnosis information handy can lead to the appropriate patient treatment. With that, it would end up lowering the risk of readmission as well as improving patient satisfaction. If you go on our website, you'll see a link towards the end of this show where there is a link to download the white paper on the decision support medicine product. And in that white paper, you'll see a full case study of an individual who presented with one set of conditions, and when the doctor was looking at information at the point of care, was able to narrow things down and see, well, actually, the conditions and the symptoms that are evident in front of me may present themselves one way, but doing a quick research, he was able to change his diagnosis and really provide that important treatment right at the point of care to get the care that was necessary in that short time frame. So you'll see examples. These are actual quotes from the product, different labels as you go through. So you may see, beware, there are other diseases that can mimic this condition, or how can I be sure that the patient has such and such a condition, or what is the differential diagnosis? So again, to have that second opinion, that safety net, instead of just being set on one diagnosis, you want to make sure you can consider others, to have that information quickly, right at bedside, in that reasonable amount of time. By seeing more patients, and we've already seen the volume of patients that would be expected, being able to be more efficient in that limited amount of time that you have with them by double checking and making sure the information is exactly what you need. So we'll take a moment to go to the live site, and I'll show you it's really a quick demonstration, as the content is really organized in such a way that it's easy to find the information that you're looking for. The navigation is fairly straightforward, and we'll go into a few quick features as well. So I've already logged in. I'm on the IP login. So for an institution, you would have a general IP authenticated login, and we'll see over here at the top right it says Swets Demo. In a little bit, or actually I can do this now, you can have a sub-user account. So now it's changed to my name. The purpose of the sub-user account is for some personalization features, and we'll take a look at a few of these as we go on through our demo. I've talked about the experts that are involved in the content. So at the beginning of every section, whether it's cardiology, pediatrics, or others, you'll find a list to the editors and the associate editors, as well as all of the contributors, and be able to see what institutions they represent. Many of them are still teaching, so you'll see a lot of them are involved in universities, university medical centers. We have Dr. Barry Greenberg is the editor of the cardiology program. We have associate editors from Harvard Medical School, Albany Medical College, Baylor, Penn State, and so on. Coming back to the contributors, the list is much, much longer, and you're going to have contributors from many different organizations from all across the country and a number of international areas as well. So as I mentioned, the total number of contributors across all programs is probably going to reach towards about 500. If we choose a topic, let's say anemia, the outline is fairly straightforward. You'll see the start of what every physician needs to know. And then the most important, as I mentioned, that safety net function, the diagnostic confirmation. Are you sure your patient has anemia? Now I'd like to draw your attention to the way that the content is presented here. One of the terms that's often used is chunked text. So what that means is it's not bullet points where you need to extrapolate further information, but it's not long narrative text so that you'll be lost in trying to find the information that you're looking for. Here you'll also see tables or images that are going throughout the content so that you can go through and find additional information in more detail. Things such as history, physical examination findings, and often what diagnostic tests should be performed, and this can even be broken down into laboratory and imaging studies. In addition to the diagnosis, you'll see management of the condition is often explained in great detail. So it's not just a condition that somebody would come one time to the hospital if they're on their first diagnosis, but many conditions may require long-term treatment. So you'll find out what's involved in immediate management, as well as management with comorbidities, since there may be times where other conditions are involved and certain things do need to be taken into account when making diagnoses and further decisions. So in this case, you'll see a number of tables that go into further detail in terms of numbers and figures, but you'll also see in a number of topics where it's applicable to see a photographic image of a certain condition or things that would enhance the clinical information in here. Those would be presented as well. You'll see up here towards the top on the right two icons. One, as I hover over, says bookmarks, and the other says notes. So let me actually choose a page at random. We'll go into carotid intervention. And let's say I want to bookmark this so I don't have to look for it further. I'll bookmark that. Then when I come to my folder, I'll see carotid intervention was bookmarked today. And this way I'll get a link right to that information instead of having to search for it again. I'll be able to pull it up right away. Let's say I'm no longer researching certain topics. They're easy to delete. Also, if I'm at a topic and I go into the content, and let's say I want to take a note. Now the note is just strictly for myself, so I want to say, please reference this information on Friday's appointment, or however I want to put in a note for myself. What it is it's really a tool for the individual to put any comments or notes. Again, these wouldn't be shared. I realize that with HIPAA and a lot of other regulations that are out there, there's always the worry of patient-sensitive information being there. But the point of the sub-account is really for self-management of the information, taking comments, jotting down notes for things that may go beyond the content that's presented there on the screen. So those are the two main personalization features. What you can also do is keep in touch with all of the new things that are going on. As we all know, medicine does not stay static. Everything that's going on changes daily, if not more often than daily. Down here at the bottom right, you'll see a link for RSS. And the way we deliver updates through DSM is through RSS alerts. This way, you can receive the information that you want to see without having to be bombarded with emails. You can simply receive the information on the topics that you're interested in seeing and then not worry about getting lost in emails. So if I pull up an example here, let me just kind of see if I can zoom in a little bit further. So this is my own Outlook, a screenshot of Microsoft Outlook. And here you'll see I've got all the RSS feeds set up in Outlook, and you can do it in whatever program you're most comfortable in. So I've got one for each of the programs, and you'll see as new programs come in with updates and things, they'll be noted kind of the same way you'd see a new email message. Very simple to notice. You'll be able to see the title of the article that was updated and a direct link that you'd click on and go right into the article. So this way, if anything is edited, you'd be able to have a link right to the article, reread it, especially if it was something that you were following closely. But all of the topics, as they have something that comes out in terms of updates, will all be done via RSS feeds. Now when it comes to searching in DSM, some people have been a little hesitant, only because the way that we search in DSM really depends upon the context of the situation. So if you're searching on something generic, so let's say I've searched on asthma in this case, and instead of digging into whether it's in respiratory, pulmonary, where am I going to find it? certain articles that are contained within DSM really depend upon the context in which the condition is found. So you'll see the first area at the top of the screen is asthma under the program of pediatrics. Then we go into asthma in terms of hospital medicine. Further detail in asthma would be found in pulmonary medicine and sleep disorders. So when handling asthma in a pediatric setting, this may be different than handling in an adult setting. And then with hospital medicine, how is it dealt in terms of an inpatient setting? So all of these articles, while they are going to address asthma, are going to have a specific focus. So being able to see and realize the context in which the information is presented is key when performing a search in DSM. This way you'll know that the information you're looking for is really presented within the proper context. So if I were to show a screenshot, for example, you may have noticed the way that the content is laid out. There's not a lot of graphics or a lot of things that are kind of confusing. Really, the navigation is built so that you can find the information easily. And one of the things that we've noticed especially is that the rise of mobile technology within the patient care sphere. So whether it's a tablet, whether it's a mobile phone, to have the information, and as I mentioned before, it's chunked text, appearing on an iPad so that a physician, a clinician, a nurse practitioner would be able to go in, quickly reference information, and generally within 30 seconds to a minute, really find the information that they're looking for, have it literally in the palm of their hand, and be able to enhance that clinician-patient relationship with this information that they were able to find very quickly. So it's more than that bulleted list, but it's not that long narrative text that's difficult to find what you're looking for. One of the things too is that a lot of these competing resources do come at a high price. The way DSM is priced is it's done in such a way where it is affordable to have as a safety net, and it's a fraction of the price of many of these other resources. And we've already taken a look through that RSS feed as to how you can stay current with new information and new content coming in. So I want to focus very briefly on three technical criteria, or really three different sides of DSM. So we balance this out three different ways. First is the access. How do I get access to it? Again, it's IP access across the institution. It's enterprise-wide. Customization. As I logged in with my own sub-account and I had that feature for notes and bookmarks, I'm able to really drill down into the things that interest me the most so that I can come back to those pages at a later time or jot down notes for my own reference and have them easily at hand. Updates, we saw a medical product is only as good as the currency of the information. So as the RSS feeds come out, you'll be alerted when new content is added into the resource. So in doing a little bit of research, we took a look to see what some of the impact was of library-based resources in a patient setting. So a study was published in the Journal of the American Medical Association. This was a multi-site study across many different hospitals and hospital systems. And it really showed that the introduction of library resources into patient care really did alter the way patient care was administered. So it's not just 25% or 50%. 70% of the responses answered yes to the following question. Did your management of a case change when presented with library-based resources? 70% is a significant number. So we know that the power of these library resources is there. Now, how did it change? If you take a look at some of the breakdown, it may have changed the advice that was given to patient or family in about half of the cases, changing the choice of medication or treatment in about a third of the cases, and even going so far as to changing the diagnosis in a quarter of cases. That's not insignificant. To put it another way, if we take a look at another study that was done in 2009, 28% of 583 diagnostic mistakes, so we're talking about probably just under 200, reported anonymously by doctors were life-threatening or had resulted in death or permanent disability. So diagnostic mistakes do happen. We did see through that map a little bit earlier that this is definitely still a hot-button issue. But again, having that safety net and having that quick reference of information is really something that can help mitigate those numbers and really lessen occurrences of missed diagnoses. It's a dynamic resource, as I mentioned. You don't need to purchase new editions or upgrades. Updates are posted through the RSS notifications, and really you're getting your top quality names at discount prices. We saw a little bit earlier the slide with all the university affiliations and the hospital affiliations, knowing that these top institutions are represented with the content presented in DSM. Names mean everything in medicine. They talk about medicine being epidemic, so whether it's Alzheimer's disease, Parkinson's, Crohn's disease, names of individuals who had done the research or who were discovering some of these conditions as they first came out. Even the medical textbook, Gray's Anatomy. Just names are really powerful when it comes to medicine. So having these top names within the program should once again help you realize that you are getting major contributors to the medical field. And all of them are leading specialists in their respective areas. I believe it's been said that it's about 22 minutes, even if not less, that the average physician has time to spend with a patient during a consultation. And again, with the number of patients coming in, it's only going to be less. And the amount of pressure that physicians, clinicians, nurses, and others feel when under that time constraint is really tough. But having the information at hand, being able to enhance the relationship and make the most out of that limited time is really what we're hoping to help out with here. We'll see the full list of programs here. There's a number that are still in development. All in all, we do hope to have about 27, 28 programs as time goes on. Quite a number of these are still available for you today, and really just keeping the research, keeping the content from the experts really easily at hand. It sometimes is like walking a tightrope. There's more patients and less time with them. Clinicians need to feel confident in the information that they're conveying. The more confidence that they portray, the better the patient's going to feel. We're always talking about doing more with less, but you need to do so effectively. Budgets are tight everywhere, and being able to do the most that you can with the limited amount of resources that you have is really a hot-button issue. Most importantly, clinicians and really anybody in the medical profession wants to be able to portray the confidence that they can support their decisions and really give the patient that sense of security that they need. Some of the main issues that are tied in specifically with the Affordable Care Act is patient management. And I know there's a lot of tie-ins, especially with Medicare or Medicaid reimbursements when readmissions are happening within a certain time frame. But by having accurate diagnoses, these readmissions can be reduced. The time, again, is less, but it can be more meaningful. Looking at the trends of technology and the adoption throughout hospitals and hospital systems, as smartphones and tablets start to make their way and those giant computer carts are hopefully becoming a thing of the past, these new technologies can really become an important part of the patient care. And again, when it comes to annual rankings, I think U.S. News & World Report I heard the other day just released another ranking for top hospitals, and some here, Swets is located within the general Philadelphia area, so some local hospitals were towards the top of the list, but really criteria such as patient satisfaction go into those benchmarks in making sure that they're satisfied, which would help improve the rank of the hospital. So in terms of next steps, there's a few things that I would point you to. You'll see information at swets.com/DSM. There is a free trial. You're able to get access to DSM. And as you exit today's webcast, there's going to be a short survey collecting some information from you. So we'll ask that if you'd like a Swets representative to reach out to you, give you some more information specifically on pricing, we can easily arrange that. Feel free to leave any feedback with regards to today's session. And check out our website. You'll see links to other resources within DSM. If you'd like to meet or basically take a look at all of the editors that were involved in the programs, so if you have a certain program that your hospital specializes in, you may even find that someone within your own institution did contribute in a large way to this program. So that's definitely a big plus if you come across that in the editor's book that's listed there on the site. So you'll get a listing of programs, the fact sheet, and many more things. I do want to allow you to type in any questions if you have any with regards to today's presentation, any of the content that you've seen. I do want to make sure that you have that opportunity to ask any questions and give any feedback if you like. Otherwise, if there are no questions, this really does conclude the presentation portion of the webcast, and I do encourage you to take a look at the site and enjoy the rest of your day.